tumor patients should know about radiation and nuclear medicine. My name is Jennifer Westland. I'm the Associate Director of National Programs and Services here at the American Brain Tumor Association. And I'm really delighted to introduce our speaker today, Dr. Frederick H. Fahey. Dr. Fahey has been the Director of Nuclear Medicine Physics at Children's Hospital Boston since 2003 and has held an academic appointment at Harvard Medical School since 2004. He has clinical experience as a PET physicist at Wake Forest University Baptist Medical Center in Winston-Salem, North Carolina, where he has been, where he was rather, an associate professor of radiology. He was also a nuclear medicine physicist and an associate professor of radiology at Georgetown University Hospital in Washington, D.C. In addition, for the past 10 years or so, he's also been a PET consultant in the NIH-funded Pediatric Brain Tumor Consortium. He received a Bachelor of Science in Physics from the University of Massachusetts Amherst and a Master of Science and Doctor of Science in Medical Radiology Physics from the Harvard School of Public Health. Dr. Fahey is currently the president of the Society of Nuclear Medicine and Molecular Imaging, also known as SNMMI. He is a fellow of both the American College of Radiology and the American Association of Physicists in Medicine. He's co-authored 70 peer-reviewed journal articles and 20 book chapters, and he's served as an expert consultant to the International Atomic Energy Agency. So with that said, thank you so very much for joining us today, Dr. Fahey. You may now go ahead and begin your presentation.
Thank you for that kind introduction, Jennifer, and welcome everybody. And I will let you know up front, you could probably tell from my introduction that I am a nuclear medicine physicist. I am not a physician. So I'm going to be talking about some of the physical aspects of what we do in nuclear medicine, molecular imaging, and although I can answer general questions about the use of PET and PET-CT in the context of brain tumor imaging, I certainly can't answer specific questions because that's just not my expertise, and that may have to be covered in a different webinar. So what I'm going to talk about today is a bit about nuclear medicine, mostly about nuclear medicine imaging, as you'll see, and radiation that is received from that, and what patients and their caregivers should know about that. I want to thank up front people who've helped contribute to this presentation, Sybil Nielsen and my colleagues Jim Adelstein and Ted Travis from Harvard Medical School. So what is molecular imaging? I mentioned that I'm the president of the Society of Nuclear Medicine and Molecular Imaging. And when we say molecular imaging, we mean the approaches that follow the paths of certain drugs and pharmaceuticals that, by using external detectors that give an evaluation of a variety of cellular and molecular processes going on in the body. So the information obtained in these studies can be very helpful in deciding the best treatment for the patient because they tell more about the function going on in the patient, not so much about what the patient looks like, but how the function in molecular processes going on. Nuclear medicine is one type of molecular imaging where radioactive pharmaceuticals referred to as radiopharmaceuticals are used to evaluate these kinds of processes. So what is nuclear medicine? In nuclear medicine, we use very small amounts of radioactive pharmaceuticals or radiopharmaceuticals, as I said in the previous slide, to trace different processes within your body. When used appropriately, it's safe, it's painless, and it's a cost-effective way of figuring out what's going on in your body. It's unique because what we're looking at is function. We're looking at how your organs are working, or how metabolism going on within the tumor, or something like that. And so in that way, it's different than CT scans or even MR in general, because it's looking at how your body functions as opposed to what it looks like. There is also nuclear medicine therapy, where larger amounts of radiation are given to treat thyroid and other diseases and some cancers. We will talk a little bit about that in this presentation, but mostly we'll be talking about the diagnostic aspects of the nuclear medicine field. So why is nuclear medicine important? Because often changes in tissue function change much before you can see changes in anatomy. So, for example, when in some cases, we can see changes in function before, let's say, the tumor changes size. We can tell that it's becoming less metabolic, or it's burning less sugar. And by that, we can tell that some change has gone on in the tumor long before we can tell that the tumor has actually got smaller. And in that way, we can sometimes use that information to guide the patient's therapy a little bit more precisely, or maybe even more quickly. So we can sometimes tell whether a therapy is being effective early on because we can see changes in function earlier than we would see changes in anatomy. When nuclear medicine is performed with using the right test, with the right dose and the right patient at the right time, it can be of great clinical benefit to the patient. It gives information to the patient's doctor about this particular patient's physiology and function, and that can be very useful in figuring out how to treat this particular patient as opposed to all other patients. And it's sort of a little bit of a window in what's being referred to now as personalized medicine. We know more about how this patient's physiology works. We can be more specific about how we treat this patient. As I said, I'm going to talk very little about nuclear medicine therapy. Perhaps you know of someone who may have received iodine-131 therapy to treat thyroid disease, either benign thyroid disease like Graves' disease or even thyroid cancer. In that case, the iodine goes specifically to the thyroid or other thyroid tissue within the body and gives a high radiation dose just to that part of the body, and thereby is a very targeted approach to therapy. There are other targeted approaches to therapy, other different cancers such as lymphoma, neuroblastoma, and metastatic prostate cancer. As far as I know right now, I don't think that there's any brain tumors being treated with radionuclide therapy, but there could be in the future. This is a very active area of research, and we see some new agents coming down the pike in other arenas of treatment in the next few years. As I said, I'm not going to spend too much time talking about nuclear medicine therapy. I'm mostly going to be spending time talking about diagnostic tests. So how does it work? And I'm using an example here of a lung scan because this happens to be the slide I have as opposed to a brain scan. But I think you can probably get the idea. So here what we have is in this slide, this image here, you can see that the agent that we're using is injected into the patient, usually by IV, but sometimes we give it orally or or even sometimes breathe it in. This agent then goes to some organ. In this particular example that I'm showing you, maybe this agent goes to the lungs and shows perfusion, that is blood flow to the lungs. We wait some time for that to happen. It takes a little bit of time for the radiopharmaceutical to go to where we want it to go. And after that time, maybe minutes, it may be an hour, whatever it is, it may even be a day in some cases, we take the patient to nuclear medicine and put them on this imaging table, and the scanner goes around the patient. Now, in this case, it's different than X-rays in that the radiation is actually coming from within the patient. So what we're making is an image of where the radiopharmaceutical went within the patient. In this case, it would have gone to parts of the lung that have good blood flow, and won't go to parts of the lungs that do not have good blood flow. So the device is actually a camera taking a picture of the patient of where the radioactivity in the patient went, or where the radiopharmaceutical went. We have different radiopharmaceuticals to go to different parts of the body. The resulting image looks something like this, and now you can get a sense, I think, that what we have is image of the two lungs. And we can tell, the doctor looking at this particular image would say, oh, those two lungs look like they're pretty well full, and they're pretty symmetric, and that's a pretty good lung scan. You can see that it doesn't have a lot of anatomical detail in the image. You can't even tell where the outside of the body is from this image, but it does tell particularly functional information to the doctor. That is, what is the blood flow to the two different lungs, and does it seem to be about even? And in this case, it does. So this is very useful diagnostic information to the doctor that he can't get from just doing an X-ray of the lungs. For example, just as an example, if you did an X-ray of a person who in fact had died, the X-ray would look pretty much the same. But this scan would be totally different because there would be no blood flow to the lungs and you would see nothing. So this information is functional as opposed to the anatomical information you might get from an X-ray or a CT scan. And here are the devices usually used in nuclear medicine. The one you saw on the previous slide looks like this. It's called a gamma camera. So it really is a camera that images the gamma rays that we'll talk about a little bit later that are emitted from the radiopharmaceutical. And as you saw on that slide, the patient lays on this table, and these giant cameras here, as you can see, can be go around the patient to take images around the patient and provide the doctor with images either from different angles around the patient or maybe even 3D cross-sectional images through the patient to let the doctor know where the radiopharmaceutical went, and then the doctor from that can determine what this particular patient's physiology is. Another device, one often used in brain tumor patients, is PET scanning. And so this is a PET CT scan. It's a combination of a CT scanner with a PET scanner. I'll show you an example of slides of that, I think maybe in the next slide or two. And again, the patient lays on the table, goes into this hole, and is imaged for some number of minutes, and from that an image is developed that again tells the doctor a bit about function of the patient. So here are three images that were acquired with nuclear medicine. There's all different kinds. As I said, there's radiopharmaceuticals that go to the lungs, as you saw a couple slides back, some that go to the bones, some that go to the heart, like this example here, some that go to the kidneys, all different sizes. But and I'll talk a little bit about these three different scans to give you a sense. The one in the middle is sometimes called a stress test, or it's a myocardial perfusion scan. Someone you know may have had this scan. It's injected while the patient is exercising often, and then imaged again when the patient is not exercising. Actually, this example here, so what you're imaging here is blood flow to the heart muscle. So if you look at this, let's say this image down here, what you're seeing here is the heart muscle, one slice of the heart muscle. The blood would actually go in the middle here where it looks hollow here. So what we're imaging is the muscle. And in this particular case, this patient was imaged both in stress and rest here when they were just lying around, and then came back and got imaged again under stress. And if you can see in this particular case, you can probably see that the blood flow in this part of the heart, called the apex, is much lower when they're being stressed than it is when they're being rested. And so that information is very useful to the cardiologist, because he can go back and say, geez, if we could return blood flow to this part of the heart, we could make that part of the heart come back, because we know it's not necrotic or dead tissue, because when at rest it does just fine. So this may be a patient, for example, who's a candidate for either bypass surgery or angioplasty. The other two images are PET scans. This is a whole body PET scan. We call it whole body even though it's sort of, you can tell where it goes from the bottom of the brain to the thighs. We often will say this goes from the eyes to the thighs. This particular case, this is a lung cancer patient, and the radiopharmaceutical used in this case was called fluorodeoxyglucose, or FDG, the very most common radiopharmaceutical used in PET. And in this particular case, FDG, you could hear it had the word glucose in it, is a glucose analog. It's basically sugar and shows parts of the body that are burning sugar at a higher rate. And so in this case, the brain uses sugar for its number one way of getting energy. The liver burns sugar. The heart does a little bit. But this is not normal here. So this would be a lung tumor. And we know that tumors are more metabolic. They're growing faster. They tend to burn sugar at a higher rate. And so you can see here that this patient has a lung tumor here. You notice that the PET scan has been overlaid on top of a CT scan. So you can now see both the anatomical advantages of the CT scan as well as the functional advantages of the PET scan. So PET CT has been a great advance in the field by being able to not say just do function or anatomy, but being able in one device do both of them. You acquire a CT scan and a PET scan on the same device and be able to combine them into an image that looks like this. If I go over here, you can see that here we have, actually this is a brain scan of a patient who has a brain tumor, and the tumor is here. Same agent, FDG. So we're using the advantage that some tumors are more metabolic, that is they burn sugar at a higher rate because they need more energy than normal tissue. And so you can tell the part of the brain here that is tumor. And in this case, we've overlaid this tumor on top of an MR scan, actually. So this isn't a PET CT scan. This is onto an MR scan in order to tell where this uptake landed vis-a-vis the anatomy of the brain. In the field of nuclear medicine right now, there are a few centers, maybe 10 or something in the U.S., that now have combined PET MR scanners, just like they've had PET CT scanners. It's still to be determined what the use of that scanner is, but it is a device that's being used in several centers, including across town from me at Mass General. In this particular case, the MR was acquired separately, and then the PET was acquired, and we mathematically combine the two into this image here. We call this the fused image to combine those two, and that works really well. So we can now take information from the MR scan and the PET scan and use them both, and that's very helpful. So what is radiation? I've told you a little bit about nuclear medicine, and I told you it emits a little bit of radiation. And what is radiation? Well, radiation is basically energy given off either by materials or devices. So radiation can be given off by an X-ray machine, a device, or by radiopharmaceuticals, by different materials. In our case in nuclear medicine, it's being given off by the materials. But in the case, for example, on the previous page where we had PET CT, some of the radiation is given off by materials and some of the radiation is given off by the CT part of the device because it's an X-ray machine. So maybe both. Lower energy radiation does not have sufficient energy or wavelength in order to ionize the molecules within materials, including your body, and they are called non-ionizing radiation. And some examples of that might be sound waves of visible light or microwaves or ultraviolet light or infrared light. Radiation that can cause specific changes in molecules called ionization is called ionizing radiation, and X-rays and the photons given off by PET scanners fall into that category. X-rays, gamma rays, and some particles like positrons fall into that category. And they can cause ionization within material, and in some cases with too much ionizing radiation, that can actually lead to some damage in the tissues. And so we'll talk a little bit about that in this presentation. So here you have a radioactive atom, and it's radioactive means it's unstable, and after some amount of time it could emit either one or two or different radiations. In this case, a photon like a gamma ray or an X-ray, and a particle like a positron, and it could emit either of these radiations. Do nuclear medicine tests involve ionizing radiation? Yes, they do, because we administer to the patient, we give an injection or something of pharmaceuticals that are radioactive. We call them radiopharmaceuticals that give off gamma rays or particles like beta particles or positrons that allow us to track where the radioactive pharmaceuticals went within the body. So what we do is take advantage of the fact that it emits this radiation so we can use that big gamma camera I showed you to make an image of where did the radiopharmaceutical go within the body. So it is a good thing with respect to being able to tell where things happen. It's not in general. The nuclear medicine scanner itself does not create radiation. It's actually injected into the patient and then just measured by the device. The exception to that is the PET CT scanner, where the PET part of the scanner is as I've described here, but the CT part of the scanner does involve X-rays in order to make a CT scan. And then, as you saw, they're overlaid on top of each other to combine both anatomy and function. We inject very small amounts of the radioactivity into the patient, so little an amount that we can do iodine scans in patients who are in fact allergic to iodine because we're given such a minute, minuscule amount. We don't have to have very much in the patient in order to make the measurements that I showed you. In addition, the radiation disappears, or as us physicists like to say, it decays in a very short amount of time. The fluorodeoxyglucose, or FDG, used for PET scanning has a 2-hour half-life. So even if it's not cleared by the body, let's say through the bladder, through the kidneys and the bladder, which it is, even if that did not happen, it would still go away with what we call a 2-hour half-life. Within, let's say, 6 hours, it would be totally gone no matter what happens. And so it goes away from the patient in a short amount of time. Most of the radiopharmaceuticals we use decay within hours. In some cases, maybe days, but usually it's in the order of minutes, hours, and in a few cases, days. Larger amounts of radiation can be used for therapy, as we talked about before. So here, what are gamma rays? Gamma rays are part of what we call the electromagnetic spectrum. They are basically like light, except at a different energy. So here you can see the whole spectrum of all radiations from the electromagnetic spectrum, going from radio waves to microwaves to infrared to visible. This is the little part of this whole spectrum that we can actually see, just this little part. I noted it with a little arrow here. And so one thing up on this slide, you can see the size of things that you can see. So even with visible light, we can see things under a microscope like bacteria or viruses, things like that. But if you want to see molecules and you want to be making measurements at the molecular level, you need to move down into this range where the wavelength is such in the order of where X-rays and gamma rays are in their energies. So X-rays and gamma rays are higher energy, but also shorter wavelengths, which allow us to make measurements that are on the molecular scale. And so it's really the same as visible light, but at a different energy. You might hear these units, and I'm just going to say them here just because I'm going to make a few comparisons and maybe it will be helpful. I'm not going to go into a description of what this unit actually means, but it's a measurement of the amount of radiation. And so the standard measurement used is the millisievert. Sievert was a physicist, so it's named after him, and then milli means 1,000th of a sievert. MSV you sometimes might see. That's millisievert is what it's called. You may also see another unit which measures exactly the same thing, dose, but in this case it's called the millirem, and that's sort of a standard traditional unit, meaning that older folks like myself use this unit, but the newer, younger folks use the millisievert. 1 millisievert is equal to 100 millirem. So they both measure the same things. In the comparisons that I'm going to show you, we're going to stay in the millisievert range of discussing things. So let me just talk a little bit about radiation by telling you that you're exposed to radiation every day. No matter what you do and where you go, there's radiation all around us, and you're exposed to that every day. We call that background radiation. And the four sources of that I've sort of outlined on this slide. Some of it comes from outer space. From the sun emits some radiation, and there's other entities out there in the universe that emit radiation that can expose us from cosmic rays. There's some radioactivity in the earth. There's some radioactive materials in just the ground. There's uranium, you've probably heard that there's uranium mines and other things, but even granite has some little bit of radioactivity in it, and we're exposed to that every day, particularly when you live in certain parts of the country, as I'll talk about next. And even a small amount of the elements in our body are actually radioactive. So we have potassium in our body, and a very, very, very small fraction of potassium is actually naturally radioactive. And so we have a little bit of radiation in our bodies, even without the administration of radiopharmaceuticals. And then anyone who's bought a house recently knows that there also could be radon gas in our houses. So the dirt around our houses here has some of this radioactivity I mentioned here, and some of that can be emitted as gas into spaces within our house, and we can be exposed to that if that space is not well ventilated, for example. So these are the four sources of background radiation to which we're all exposed to every day. The average radiation dose to someone in the United States from background radiation is about 3.1 millisieverts. Again, this is just a unit of measuring radiation. with 2.3% of that coming from the 2.3 millisieverts of that coming from the radon in our houses. So most of this comes from radon in our houses, and the other 1/3 of it comes from these other three sources. And as I said, it depends on where you live. So for example, if you live in Colorado, you get higher background radiation for two reasons. One, you're at higher altitude, and thereby the air is thinner, and you get more cosmic radiation. And in addition to that, the Rocky Mountains are made of material that tends to have a little bit of radioactivity in it. And so people who live in Denver or in the mountainous areas to the west of Denver get a little bit higher background radiation than people who live on the East Coast, let's say in New Jersey, as you can see, about 1/3 higher. So although the average is about 3 millisieverts across the U.S., it can vary depending on where you live and whether you live, for example, in a house, a brick house that may have more radon or a wooden house that may have less. So it depends on where you live in that case. But it's on this order of about between 3 and 4 millisieverts. So keep that in mind when we talk about medical imaging. This is a pie chart that was published a couple years ago in this report that shows the average exposure to a person in the U.S. The estimate was that the average person in the U.S. gets half of the radiation they get in a normal year from background radiation, about 3 millisieverts, and they get an additional 3 millisieverts from all the man-made sources, almost all of it medical imaging. So you see, for example, that CT scans contribute about 25% of the total amount of radiation, average radiation that someone gets, and nuclear medicine about 14%. So compared to the natural background. So in general, we're getting a fraction from nuclear medicine compared to what you normally get just without going anyplace. But you get something, and so if you add this all together. Now this is average in the U.S., so you can imagine that there's some people that get none. I did not have a radiologic exam for the last year, and then there's some people who get several radiologic exams in a year. But the average to a person in the U.S. is about that they get about 3 millisieverts from natural background and an additional 3 millisieverts from medical imaging. 14% of that is from nuclear medicine. So what can people get who, you saw 3 millisieverts from natural background, 3 millisieverts from medical imaging. What do people get who work with radiation every day? Like the nuclear medicine technologist here, you see the gamma camera in the background imaging this patient here. Here's the PET CT scanner with the CT part in the front and the PET in the back. You can see the technologist there. Or just an X-ray tech imaging this patient here with an X-ray tube. And what do they get? Well, according to the regulations, they can get 50 millisieverts every year. So the regulations, the law that specifies what these workers can get allows them to get 50 millisieverts in a year, and they could get that every year. In general, these people get significantly less than this, maybe 10% of that. So your typical nuclear medicine tech perhaps gets 5 millisieverts per year as part of their job, 1/10 of what the limit is. Maybe they get 3 millisieverts, something on the order of background. So maybe they double background. But the workers in radiology who work with radiation every day are allowed to get this much, but routinely get about 1/10 of that. So a lot of other things around that we do also emit radiation, and I'm trying to give you a little bit of comparison here. Some of them are stuff we do all the time. Watching TV, particularly in the old days of cathode ray tubes, had a very small amount of radiation that came out of it. If you fly to the West Coast from DC to LA, you get about 0.05 millisieverts. Not too much. How much do we get from radon? As we said earlier, you get about 2 millisieverts, and the average background, as we said, was 3 millisieverts, and a worker can get as many as 50. If you look at the radiations from medical examinations, you can see chest x-rays very small. It doesn't take many x-rays to get through the lungs because they're mostly air. A nuclear medicine thyroid scan gets about 0.14 millisieverts. A mammogram gets about 0.4 millisieverts. A nuclear medicine lung scan, like the example I showed you earlier, about 2 millisieverts. And if we come down here, something that may be interesting to us might be an FDG scan. Here, PET-CT scans more like 14 to 20 millisieverts. So you get a sense that that's about maybe equal to 3 or maybe 3 or 4 times what you get from background, what you get from background. And it's because it's a little bit higher because it's a combination of both a CT scan and a PET scan. Maybe about 8 millisieverts from the CT scan and an additional 8 millisieverts from the PET scan. How much ionizing radiation is received from medical imaging? So as we said, the average effective dose from a radiologic medical imaging depends on the test being done. Not so much maybe for a chest x-ray and perhaps more for a CT scan or a PET-CT scan. It probably in general is about the radiation that one gets from about 1 to 3 years background radiation, if you look at that. Maybe in some cases up to 4. But it's several years of background radiation. So you get that, get almost a third of that just from background, and significantly less than the amount that our radiation workers could get in any 1 year. How much radiation is safe? That's a difficult question to answer. We know from a number of different studies that high levels of ionizing radiation can lead to unwanted health effects, including cancer. We mostly know this actually from following the survivors of Hiroshima and Nagasaki, the atomic bomb survivors of Hiroshima and Nagasaki that we've been studying for 60 years. And we know that people who get higher levels of radiation do, in fact, have a slightly higher rates of cancer, and we'll talk a little bit about that. There is no direct evidence that the level of exposure from ionizing from nuclear medicine or even from radiologic exams leads to these effects. But it seems to be prudent to assume that perhaps it does, but at a much lower rate because the doses are much lower. So the assumption is, and the prudent assumption seems to be, that every exposure to ionizing radiation has some small risk associated with it, although it could be very, very small and perhaps even non-existent. Carries some small risk of an unwanted health effect, including cancer. And what is the size of that small risk? And well, before I get to that, are there some populations that we think may be at higher risk than others? And it turns out, you won't probably be surprised, but compared to an adult, that children are at a higher risk, possibly, maybe twice the risk or maybe 3 times the risk, because their organs are actively dividing, their cells are actively dividing, and that tends to make them a little bit more susceptible to these kinds of changes. And we also know that young women, young teenage women, may be slightly higher again, maybe a factor or 2 higher than a 40-year-old. And then we know that the fetus is perhaps a higher sensitivity as well, and so we try to avoid doing these kinds of exams in pregnant women. And I work at Children's Hospital, as you heard, and I've been involved in the Pediatric Brain Tumor Consortium. And so we do images in children, but we just make sure that we keep the doses as low as possible while still giving the doctors the excellent information that we can provide about function and anatomy in our patients. Is there a risk associated with nuclear medicine? Well, there possibly is, but keep in mind that practically all medicines or medical procedures have some side effects associated with that, and that way nuclear medicine is no different. When a recommended test is given, the benefit for that test most likely far outweighs the very small possible risk. And as I said before, when we use it on the right patient at the right time with the right dose, it's very safe. And again, the benefits for that test far outweigh by many orders of magnitude the very small potential risk. So what is the size of this risk? And this, again, is perhaps controversial. Some people would say there's no risk at these very low doses, let's say 10 millisieverts. But the prudent thing is we don't know, and so we should be safe, and we should try to work safely. But given the most up-to-date models of radiation protection, we think that this level, 10 millisieverts, that may be, as you remember, that's about 3 times background radiation. That's maybe a little bit more than a CT scan and a little bit less than a PET-CT scan. So just to put that in context, perhaps leads to 1/20th of 1% increase in the cancer rate in those individuals. So quite small probability that this patient could have a fatal cancer. 1/20th of 1%. Compared to the natural chance that some people in the U.S. die of cancer, which is 22%. So you can see that that this is about 1 in 2,000, whereas about that's about 1 in 2,000, and in that 2,000 people, about in fact something like 400 people will naturally die of cancer in that population. Each exposure carries its own very small risk, and that way the fourth PET scanner has about the same risk as the first PET scan. They're all about the same. Every time you have a procedure, it has a very small risk, depending on that procedure and depending on what part of the body is exposed during that procedure. So how do you compare that to perhaps other things? And some of these, I put these up for comparisons, but it's sometimes the types of risk and how it's perceived is very different. So if you look at the risk from getting a PET scan, perhaps 1 in 2,700 folks who get a PET scan will actually get a fatal cancer from that. That kind of risk of 1 in 2,700 is pretty small. It's a smaller risk than the risk of people that someone in their lifetime will die falling down a flight of stairs. Not the chance that they'll fall down a flight of stairs, but that fall down the flight of stairs will be fatal. So, in a way that may be, I think that may be a reasonable comparison, because we understand that there's a risk walking up and down stairs. We still do it because the benefits of being able to get to the second floor where my bedroom is far outweighs what I perceive to be the small risk that I take walking up and down the stairs. And I think you can put this in the same category. The benefits when the PET scan is ordered appropriately far outweigh very, very small risk that is associated with this scan. This is a little bit of a tricky slide, and so it has here radiation workers, someone who works in radiation, and how many days do they lose from their life because they've got exposed to, maybe 5 millisieverts every year for 20 years or something like that. And you can see other risky behaviors listed on this table, like being a male. If you're a male, you lose something like 8 years of your life compared to being a female. If you're 30 pounds overweight, which I'm a little bit sensitive to, you can see you lose about 3 years of your life. If you drive in cars, there's a potential that you could lose a half a year of your life. And this radiation worker who received 5 millisieverts every year for 20 years loses 25 days. Now, you can keep that in mind. That's average. This is average over the population. So there's a lot of people who don't lose any, and there's some that lose more than this. So you can keep that in mind. But this just tries to put this a little bit in context. How much radiation would be considered too much? Well, in the context of medical imaging, more than we need. Anything more than we need, we would consider too much. Each procedure takes a certain amount of radiation to be done appropriately. If we use a lot more than that, we're exposing the patient to unnecessary radiation. And if we use too little, we can't get the study done appropriately, and we're not going to give the doctor any information, appropriate information. So using either too much or too little is probably a bad thing, and we want to optimize it to use the exact right amount. So you'll hear us sometimes physicists talk about dose optimization. What is the right dose to do the test correctly? Each procedure is optimized that word again, for the medical task at hand. What are we trying to find? Are we trying to find a tumor? Are we trying to determine whether the patient has good blood flow to their heart? Are we trying to determine what the blood flow is to the lungs? And the equipment used, new equipment probably allows us to use less radiation, and the patient, the particular patient. Certain patients may require more radiation than others. Larger patients may, or, for example. A lot of patients are going to then go back to their doctor perhaps and ask, well, is this test necessary? I can't answer that question. That is a question you should ask your doctor whether it's necessary, and for a number of different reasons, including perhaps radiation, but maybe that's not the only reason. And the question sort of to ask your doctor, I think reasonable questions to ask your doctor if they're recommending an exam that you're not comfortable with, is what will you learn from this procedure, and how will this procedure affect the course of my treatment? Will this procedure tell you something that's very critical for figuring out what's going on with me and how you will move forward with my case? And if the doctor gives you an answer that gives you feels like, yes, this is going to help me figure out how to treat you better, then that obviously is going to be a great benefit to you, and the benefit will far outweigh the risk. As I said down here, this is part of the SNMMI dose optimization statement. When the right procedure with the right dose is performed in the right patient at the right time, it can offer very useful clinical information that can help your doctor decide on your treatment. And the benefits of the procedure far outweigh its very small potential risk. If a patient then decides not to have the test because they're afraid of radiation, that could in fact be detrimental to the patient's health because they may be denying information that really would have been helpful. For example, one use of PET scans that has been used is to determine whether therapy is being helpful. So you put the patient on, you do a baseline scan, you put the patient on a new therapy. This is in fact also been used in brain tumors, and then you see that the metabolism of the brain tumor goes down significantly, or the cell proliferation or the protein synthesis or some other molecular process drops significantly within maybe just a few weeks, even before the tumor has actually shrunk, and you can see, yes, this is an effective therapy and we should continue with this. If it doesn't, you might say, this isn't being very effective, maybe we should look for a different therapy. So molecular imaging in nuclear medicine can be very helpful in determining whether the therapy that the patient's receiving is actually being effective in certain cases. I don't know about your particular case, but in certain cases that has been very helpful. What is the imaging community doing to try to keep the doses optimized, to try to keep them as low as possible and still get the excellent results of some of the images I showed you earlier? Well, there have been two groups that have looked into this specifically. First, there was the Image Gently campaign. If you're interested, they have some information for patients. Go to imagegently.org, and they talk specifically about pediatric imaging, and a lot of excellent work in trying to guide people to use the minimum amount of radiation necessary in order to get excellent scans. And then more recently, the imaging community said, geez, if this works really well in kids, how about adults too? And so the Image Wisely, this wise old owl over here, campaign was started about a little bit 2.5 years ago, and that is dealing with dose optimization in adult imaging. If you look at these two websites, you will find someplace on these websites some area of the website that talks about nuclear medicine specifically. You'll find part of it deals with CT scanning specifically, but also nuclear medicine. So these are excellent resources for getting some information about nuclear medicine as well as CT scanning. Both campaigns promote the appropriate procedure for the specific patient, this patient, you, with the minimum amount of radiation necessary to provide useful information. Provide information to the patient. And these websites, if you look at it, provide information for not only imaging professionals such as myself with respect to dose optimization, but you'll also find some information on these websites that is useful for patients as well. The SNMMI has recently launched a web page with covering some of these topics as well. This is the website. It's mostly professional information, but patients might also find it useful. And on the next slide, I'll direct you to a website that the SNMMI has put together that has information specifically for patients. So here, as I just promised you, right here, this discover.mi.org. If you go to this page, it has specific information that the SNMMI has put together about the use of nuclear medicine molecular imaging in patients. And this page is specifically designed with patients and their caregivers in mind. The SNMMI a couple years ago established a patient advocacy advisory board. We're happy to say that the American Brain Tumor Association is represented on our board very actively. They're a very active member of this patient advocacy advisory board, and they told us that a lot of what they thought should go on this page, and had a lot of input into this page and what kinds of topics we should cover. And in fact, this presentation I'm giving to you today came out of a discussion from the Patient Advocacy Advisory Board, who said we really need a lay presentation that describes radiation in the context of nuclear medicine that's aimed at a lay audience and patients. As I said, we have put together some information. You can go to this page and you might find some useful information. If nothing else, this will give you links to Image Gently and Image Wisely as well. The Radiologic Society of North America has launched this radiologyinfo.org page. If you go to there, this information is specifically for patients and their caregivers. And the Health Physics Society, which is the professional organization of radiation safety and radiation protection professionals, and they have a public information page. So if you go to this website, HPS, healthphysicsociety.org/public information, they have a lot of very excellent information as well. And then, as I said, Image Gently, Image Wisely here. And lastly, if you go to the National Institutes of Health, they have a specific page that talks about radiation in the context of NIH research subjects. So it has come up that, I've been asked to be part of a clinical trial, and what should I know about radiation with respect to being a subject in a clinical trial? And maybe this is appropriate for a number of you folks or your family members who are also interested or have been offered a possibility of being part of a clinical trial that has as part of it CT scanning or PET scanning. So that is my presentation. I hope that you found it helpful. I hope I didn't raise more questions than I answered. It was a pleasure to be able to speak to you today. I really appreciate the invitation from the American Brain Tumor Association to be able to be given this opportunity to visit with you today. And thank you very much. If you have any questions, I think you saw at the beginning I had my email address, and feel free to email me, but I can stick on the phone for a number of minutes here to try to answer any questions that you may have. And with that, at this point, I'll turn the program back over to Jennifer.
Thank you so much, Dr. Fahey. We really appreciate you being here with us today and for sharing such great information. I just wanted to make mention, too, the last slide that Dr. Fahey showed with all the useful websites. We have created a resource sheet which includes all of those, which we will post on our website shortly. In fact, if it's not already posted, and it will be housed under the Treatments tab of our website. And then if you click on the sub-navigation that I believe says radiation, there's a resource page there. Like I said, if it's not there yet, it will be shortly. It does look like we have about 10 minutes remaining for questions. Dr. Fahey's graciously agreed to stay on to respond to some questions. And just as we provided this little bit of a caveat earlier, I just wanted to make mention that Dr. Fahey is a Doctor of Science in Medical Radiological Physics, not medical doctor. So if you could try to sort of narrow your questions to his area of expertise, that would be helpful. It looks like we have received a couple questions, and Dr. Fahey, please stop me if I'm asking questions that aren't quite appropriate for you. But one of the questions that has popped up is from Tina in California, and she asks, what are some of the side effects of radiation that I should keep in mind?
So thanks, Tina, for the question. As I mentioned, with respect to the imaging side and even for the therapeutic side, there are very few side effects to a PET scan or even a CT scan that you will experience at the time of the scan. We inject, as I said, I mean, sure, we have to do an IV injection, and that stings for a couple seconds, but beyond that, it's a pretty benign scan. Then you wait around for that radiopharmaceutical to go where it's supposed to go, and then you lay on the table for about a half an hour to get the scan done, and then you can leave. So there really isn't any side effects at the time that the scan is done. As I mentioned in this presentation presented, there is a very, very small risk, like a 0.05 percent risk, a 20th of a percent risk or less than that, that you could contract a cancer because you had the scan, but it's very small, and even in there perhaps even some scientists who don't even think that the risk exists, that the body is able to protect against such a small radiologic insult. And so if there is any, it's very, very small. In general, there's no immediate side effects to the kinds of scans we do beyond having a IV injection.
Thank you. The next question comes from Kevin, and he wonders if you could comment on the pros and cons of MRI use versus PET, perhaps specifically in brain tumors.
So, again, I will just use I will give you a short answer on that, but keep in mind that I can claim my physicist ignorance to some extent, but I can tell you a little bit because I have been, as Jennifer mentioned, working with the pediatric brain tumor for a while, and as part of that, we're part of the neuroimaging center, and we get both MR scans and PET scans on these patients. So MR gives you an excellent image of the brain anatomy, and you can see the gray matter, the white matter, the different parts of the brain, and it's really wonderful pictures of high anatomical detail. What it doesn't do as well, perhaps, is tell you what's functionally going on in the tumor at this particular time, or even some remnants of tumor after therapy. So, for example, one application for PET where it's been shown to be quite useful in brain tumors is in the evaluation of tissue changes after radiation therapy, where it's sometimes you can tell that there's something that has gone on in the brain that's different on the MR, but it's not that easy to tell whether it's recurrent tumor or whether it's just radiation necrosis from the radiation therapy in the brain. So if it's necrosis, that's because that part of the brain tissue has died because of the therapy. That's an okay thing. We understand that would be happen, and we hope that when that happened, that the tumor cells within that same area also died. It's not that easy to tell. It looks on the MR sometimes that looks exactly like recurrent tumor. The PET scan can be very helpful in that example, because if there's uptake in that part of the tumor that we think might be necrosis, i.e. dead tissue, but we see that there's uptake, FDG uptake, meaning there's metabolism and there's sugar being burned in that area. That means it's not dead, and that could be indication that that's recurrent tumor. So PET scanning, for example, has been shown to be very helpful in trying to determine the difference between necrosis and recurrent tumor. And as I said before, a number of different places like UCLA have been using PET scans to be able to know earlier on, measuring what we call the response to therapy. We do a therapy, we want to know as early as possible whether that's making a difference for this patient, and PET scanning has a lot of promise in that regard. And so, which is not seen as well on MR. MR, you would have to wait until the tumor changes the size. I mean, that might take, a bit longer than the PET scan has shown. So being able to measure progress or how effective the therapy is, PET scanning might be more efficient in that than MR scanning. But as I showed you, maybe the best approach is going to be using both, as I showed you in that one example, where we take the wonderful anatomical information from the MR scan and combine it with the functional information from the PET scan and really get a much more complete picture of what's going on in the patient, and that really may be the best of all. So as part of the the PBTC, the Pediatric Brain Tumor Consortium, when we review the PET scans that come here, we never look at them without looking at the MR scan at the same time. We find that the information is complementary rather than showing us exactly the same thing.
Thank you so much. Looks like we have a little bit of time left for maybe another question or two, and I'm just kind of wondering, we've heard so much in the news in various journals, in various e-zines that we get regarding the use of PIB with Alzheimer's disease. I'm wondering if you're seeing anything out there in the research and how that might specifically apply, if it applies to the brain tumors.
So PIB, and more importantly for our imaging community, probably some of the fluorine-18 labeled versions of PIB, emit, developed by, being marketed right now by Lilly, is a fluorine-18 version of that same that agent that was approved by the FDA almost exactly a year ago. Measures amyloid burden in the brain. Amyloid is a hallmark of Alzheimer's disease. And so the ability to measure that we used to only, before 10 years ago, the only way you could determine what was the level of amyloid in the brain was to wait until after the patient died and it was evaluated on autopsy. Well, now we have an imaging test, a PET imaging test, similar to what we've talked about over the last 45 minutes, that can measure amyloid in the brain of patients who possibly have Alzheimer's disease without having to wait until pathology. I don't think that there is a role for PIB or amyloid imaging in brain tumors specifically, although there may be more than one pathology going on in a patient. So I don't think there's a specific role. Again, I'm the physicist, and a neuroradiologist or a nuclear medicine person, physician who understands neurology very well may be able to answer that differently than me. But I think right now I don't know of a specific role. It's specific to Alzheimer's disease.
Okay. It looks like we've run through all of our questions, and it's just about 3 p.m. here Central, so it looks like we can go ahead and wrap up for the day. Dr. Fahey, I wanted to say thank you so much once again for joining us today. SNMMI President Dr. Fred Fahey of Children's Hospital Boston and Harvard Medical School